Hello everyone, today we shall look at cutaneous tuberculosis. I am Dr. Abraham from A&E dermatology specialist. So in this case, TB or tuberculosis can also affect the skin, and it's actually very fascinating that in most of the cases, these patients are diagnosed late because of lack of knowledge that this also exists. So today we shall shed light on how TB affects the skin and the different way it presents like if it affects the skin. So tuberculosis is one of the notorious bacteria that has been recognized over time. And this bacteria is very, very common, especially in our settings, and it has been shown to be actually the second commonest cause of infectious deaths, second to HIV, and sometimes it also occurs in HIV, or actually most of the times it affects people living with HIV. So the bacteria itself, the Mycobacteria tuberculosis, is a slender, non-motile aerobic bacteria. It doesn't form any spore, but it is a rod, and it has a waxy coating we call mycolic acid that usually is very, very resistant to the environment, and it's also very resistant to the laser staining. So if we are looking for it, you have to do a special stain. And what you have not here is that it's also one of the slow-growing bacteria. So this group has about 190 genotypes that have been recorded, but about 30% or only 30 of them have been implicated in human diseases. And tuberculosis of the skin or skin TB only contributes to 1% of all the TB infections. So majorly, it is usually causes pulmonary disease or TB of the lungs. So the clinical picture usually is determined by the host immunity. If the host immunity is good, then the response is different when compared to someone whose immune status is a little bit compromised. So depending on the immune status, we can have categories where we say allergy, where there's no actual response. Someone gets a TB infection, but the immune system does not actually respond, so the bacteria grows. Then we can have hyperresponsiveness, whereby you just have reduced immune response, or it can be the normal response if someone's immunity is okay, or hyper-responsiveness. So all these give rise to different clinical picture of the skin manifestation of TB of the skin. So worldwide, it is estimated that tuberculosis affects a third of the general population, and it is the second, as I mentioned earlier, it's the second infectious cause of death, second to HIV, and tuberculosis of the lung contributes up to the 98% of all cases, and even the bacteria in tuberculosis contributes 98% of all the mycobacteria infections that humans get. It has an incubation period of about 6 to 8 weeks. That's why even when you're culturing it, you may find that you need actually the same exact time, even when you're using either solid or liquid media. And the bacteria reaches the skin either through endogenous route or exogenous route. For example, if someone gets into contact with sputum that is infected, they can get skin manifestation or skin infection. So that is exogenous. But if someone already has pulmonary tuberculosis, and then the bacteria moves through blood or lymphatics to end up in skin, that is endogenous spread. Then what I mentioned earlier, that they have this special mycolic acid that can only be stained by a special stain or a special method. We call the acid-fast staining. And in the diagnosis, we usually depend on clinical history. You can do a PCR, a chest X-ray, culture and sensitivity, and we can also do the Mantoux as well as the urine alarm. So this is how the bacteria will look like. It is a rod, as you can see this shape here, it is a rod. Then it will have these different components, the chromosomes, the ribosomes, the flagella, and the rest. But most importantly, in its cell wall, we have a component we call mycolic acid, which I have illustrated here. So if this is the cell wall, you'll have the different components. This is the cell membrane, the lipid bilayer. But in the cell wall that is outside the cell membrane, in the normal bacteria, we will have the peptidoglycan. And depending whether the bacteria is gram-positive or gram-negative, the size of the plaque-like will vary. But on top of that, the bacteria in this category, they have the different mycolic acid. So this adds an extra protection layer and making it very hard to stain on just a routine gram stain. So that's why they're called acid-fast bacteria, because you have to use heated processes when you are staining them. So the virulent factors that make this bacteria very notorious include the following. The first one being the cell wall. So we would say the cell wall has mycolic acid, it has the lipid, the lipo arabinomannan acid, they also called LAM, and also it has the code factor. All this improve the protection and allow the bacteria to evade the immune processes, including phagocytosis, including attack by the lysosomes, so they can thrive even inside immune cells. Then you also have the ESX1 excretion system, and in this case, you have proteins that help the bacteria to escape the immune system by disrupting actually the immune membranes or the cell membranes of the immune cells. Then you have the pH excretion system. This one has genes that regulate for immune evasion and virulence. It also has the CATG enzymes that protect the bacteria from oxidative stress in the macrophages. We know that after the bacteria is taken up by the macrophages, usually the macrophage will attach that phagosome with the lysosome such that the bacteria is destroyed. But now, in this case, the bacteria has protective enzymes that are able to break down the hydrogen peroxide, the nitric oxide that is within these phagosomes. Then iron acquisition, the bacteria is able to scavenge iron from the host cell cells, and this usually allows it to flourish. Then we have dormancy regulation. This helps the bacteria to survive in a dormant stage under very low oxygen tensions. This now allows the bacteria to establish latency, which can be as long as your lifespan. And we have also them expressing the antigen 85 complex. This usually hits in the cell wall and the immune evasion. And also they have heat shock proteins that enables them to survive under host-induced stress. So when we are looking at the mycobacteria, the general infection can be classified depending depending on the different stages. And the first one, usually after getting into contact with the person who is infected and they are coughing, you will get respiratory droplets that you breathe in that will enter your lungs. So upon them entering your lungs, usually they'll be internalized by your immune cells, the ones we call macrophages. And when they're inside the macrophages now is trying to break down the bacteria, but the bacteria is able to evade because of the virulence factors that it has. Then your macrophages will remove will now start to sense the pattern, the particles that are associated with pattern recognition particles that are very important to induce the immune system. So that will produce for you the cytokines. The additional phagocytes will be recruited in that area to try and come and fight the infection. And sometimes your immune system wins, so you will cure. But in case it doesn't, then the bacteria will survive in the phagosome by the EXX1 secretion system that I've talked about. So in this case, they now survive and actually even multiply within your macrophages. So after that, they can now start to spread to the nearby tissues. And if they're infected, they'll now move to the nearby tissues, those are usually the lymph nodes. And then in this case, you have priming or activating of the different T cells to try and fight these infected macrophages. But sometimes still your body fails, then the TB will now progress to give you symptoms, or your system can actually win. So these are the processes. Either your system can fail and then the TB persists now to form a granuloma, or your system wins and then you're able to clear. Or sometimes the TB can turn out to be latent, then it remains in your system forever. So the steps of infection, we can summarize them here. We have inhalation and ingestional infection, which occurs after you've taken in the bacteria through your nostril when you're near someone who is infected and then they are coughing near you. Then after that, the initial infection site in the lungs, we will call it focus. This one, I think, if you look at it in general medicine, and if nearby lymph nodes are affected, it becomes a primary complex. So if your body is not able to eliminate the bacteria, so it ends up walling it off to form a granuloma. So the next step will be granuloma formation. So in this case, usually the center undergoes caseous necrosis. So then you have the typical caseous necrosis we see in tuberculosis. Then, if you have your gone focus plus the primary infected lymph nodes, this one becomes the gone complex. And sometimes, because of the healing processes, especially if it is in the lungs heal by fibrosis, so they can calcify later on, and then this is usually visible on X-ray. So that becomes the Ranke complex. And then sometimes your body is able to clear it, but if it is not able to clear the bacteria, then you get latent tuberculosis. So even the bacteria in this group can be classified depending on the disease manifestation that they give on skin. So sometimes, depending on the host immunity, your body is able to actually clear most of the bacteria. So meaning that if you take off that sample, the number of bacteria you're able to see, they will be low. But in case your immune system is weak, the bacteria multiplies a lot, and then when you take off a sample, the bacteria that you can pick on that sample, there are very many. So those are the two forms that we have. So the first one, we call it the multibacillary forms. So in this case, your immune system is not able actually to clear the bacteria very, very fast. This can occur in a naive host who has never been vaccinated or infected by the tuberculosis. Then in this case, it can either be direct inoculation onto the skin, and then this will give you a particular skin manifestation that we call tuberculous chancre or primary inoculation. And then sometimes someone can just have a low immunity. So if your immunity is low, then depending on the spread, you can get different skin manifestation. We're going to look at all of this, the scrofuloderma or facial tuberculosis, then acute cutaneous TB, and then the TB abscesses, also called tuberculous buma. Then the past bacillary forms, this one simply means that your immune system is intact. It knows about the TB, so it mounts a good immune response. So when you take off this sample from, in this case, the organisms that are able to see are very, very small or few, or even not even detectable in some cases. So this occurs if you have a good immunity. So now that will give you a different clinical manifestation. So it can give you wart-like tuberculosis, the common form of TB, the lupus vulgaris, and then all the associated tuberculosis also fall under this category. So starting with the first clinical variant of tuberculosis, the first one, we call it the primary inoculation tuberculosis, and this is also called the tuberculous chancre or tuberculosis primary complex. So in this case, someone is a naive host, they have never been infected or vaccinated against tuberculosis, and you get this infection from maybe contact with maybe infected fomites or even sputum. And this is usually commonly seen in children and healthcare workers. So you are working in a hospital setting, then you have a TB patient who coughs on linen, and then you touch that linen unknowingly, then you end up with inoculation of the bacteria into your skin. So this is when this comes in. So it can also occur in exposure, different exposures, maybe through injuries, cuts, needle prick injuries that you see, toothing, or even piercings that people usually do. And it is also common in people living in low resource settings, overcrowding, and where you have no BCG vaccination or no vaccination against the tuberculosis. So the clinical presentation, someone will present with a painless, non-healing ulcer, which is usually which usually comes with a localized lymphadenopathy. So oftentimes we see it on the face, hands, extremities, these areas that are usually in contact with the environment, and it usually appears about 2 to 4 weeks after inoculation. So if you have the incidence today, then 2 to 4 weeks later, then you get this non-healing ulcer. Then it may resemble other skin conditions like leishmaniasis and sclerotrichosis. And the diagnosis, basically, you have to do calcium sensitivity, then you can do a tuberculin test, which is usually negative initially, but later on it turns out to be positive because we've known in the pathogenesis that you form the antibodies later on in the disease process because the bacteria first hides from your immune system. Then it can complicate into lupus vulgaris, scrofuloderma lesions you're going to see, or even systemic tuberculosis. Management is the standard antibacterial therapy. And then in this case, you can also vaccinate the patient with BCG if they have never been vaccinated. And this primary tuberculosis inoculation can occur in settings of Mycobacterium tuberculosis in bovis or even following vaccination. So the second one is scrofuloderma. So in scrofuloderma, you have a direct invasion of the skin by tuberculosis from an underlying tuberculosis focus. So someone there has TB, maybe TB of the bone, TB in joints, TB in different organs, but now it just extends to affect the overlying skin. So this is also called the tuberculosis cutis, commonly seen in the cervical areas, the epitrochlear areas, and the retroauricular lymph nodes, and sometimes commonly seen on the neck, face, and the axilla. But most cases that we've seen usually are around the neck and the axilla, but may also develop on the scalp, ribs, and then also breasts and testes. So as you can see in this picture that we have here, so someone has TB of the lymph nodes, and now the overlying skin is getting affected. So someone has multiple ulcers, nodules with purine discharge that don't heal. So even whereas they are healing, then another one develop just nearby. So in this case, you need to take off a swab for ZN, and then you find if you are able to pick the bacteria, then you start anti-TB medicine, and the patient will be better. So scrofuloderma is one of the common forms of cutaneous tuberculosis worldwide, especially in children and young adults. And it is most common in the first decades of life, that's around the first 30 years. And usually male more affected than females. There's a slight predilection for males, but risk factors still include HIV infection, poor living condition, and then also if a patient has already systemic tuberculosis. So still in histology, you see ulcerated dermal abscess with caseous necrosis and a few granulomas, but with numerous bacteria in the deeper tissues. So when you do H&E stain, you're able now to see the granulomas, and you can go ahead and do the pus staining, then you're able to see the bacteria. So in the clinical picture, someone can have a bluish red subcutaneous swellings that usually break into ulcers and sinuses, and may form granulation tissue overlying the ulcer. Someone will have different fistula and then pockets of scars that have healed. And then sometimes you can have also spotrichoid pattern of extension where it follows the lymph nodes. And in the differentials, you can look at the atypical mycobacterial infections. You can look at all the diseases that can cause spotrichosis or spotrichoid spread, including spirochetosis, actinomycosis, and syphilis. Also, if it is occurring in the axilla or in the genitalia, you can also think about hidradenitis suppurativa. Then, in this picture that you see here, so this patient had TB of the scalp bone, the osteomyelitis of the scalp bone, secondary to TB. Then they got an overlying extension to the skin, giving us this ulcer here that you are seeing on the skin of this child. So after giving anti-TB medicine, the ulcer was able to heal. So now you see now this one also looks like a pyoderma gangrenosum. So cutaneous TB will be also a differential in case you see similar cases. So in this case, you have to take off the biopsy, then you look at it under the H&E, and then also pass staining. Then the second type, we also call it orophyseal tuberculosis. In this case, someone gets TB affecting the oral mucosa and the nearby structures, including the lips and nose. And it is usually characterized by these lesions which are usually around the lips or even the nose, with serous discharge, non-healing ulcers that take long to go away. So when you see such a patient, you have to screen them for TB. This orophyseal tuberculosis can also be called tuberculosis cutis or fisharis, and commonly involves the oral mucosa, especially the tongue. Can also be in the anus vulva as well as the penis. And oftentimes you have secondary it occurs secondary to pulmonary TB that is advanced, that ends up being disseminated to the different organs. So this is also a little bit rare type of skin of the TB, and it allows people in the middle ages or even the elderly. And risk factors, including someone with advanced systemic tuberculosis, especially those with immune suppression, those on chemotherapy medicine, HIV infection, malnutrition, transplant patients. You have to think about tuberculosis every time you see a mucosal ulcer that is not healing. Then histopathology will also show you the tuberculoid infiltrate with the Cutaneous necrosis, and then you are able to detect the Mycobacterium and you do the pus staining. So still in this oral ulcer that you see here in this patient, when a sample was taken off and after staining, they discovered that it was Mycobacteria tuberculosis that was causing the ulcer. So the clinical picture, in this case, someone presents with painful shell ulcers, which can have a bluish undermined edge and most commonly seen in the mouth and the anal areas. Someone can have the symptoms of fever, weight loss, night sweats, as well as other signs in systemic symptoms seen in tuberculosis. So differentials, since it is around the oral mucosa, you have to think about oral Crohn's disease, syphilis, chronic herpes simplex infections can give you chronic ulcers, especially in the immune compromised. Then you have to think about malignancies, the squamous cell carcinoma, basal cell carcinoma, which can also occur in the mouth, as well as Kaposi sarcoma. So in management, we just give the anti-TB medication depending on the guidelines that you're following in your country. So then we can also have the acute cutaneous mediated tuberculosis. This is very, very rare form of cutaneous TB. And in this case, it is thought to be caused by blood or hematogenous spread. So in this case, you have another focus, maybe the lungs that are affected with tuberculosis. Then someone ends up getting spread to the skin through blood. Then it is also called tuberculosis cutis miliaria disseminata because it is just disseminated TB from another primary focus. Can also be called tuberculosis cutis miliaria acuta generalista, which is just simply means generalized skin tuberculosis. It's also due to Mycobacterium tuberculosis, risk factor, advanced pulmonary TB, or even TB of the meninges, common in child, infants, and then also immune suppressed individuals. So this is a rare form of tuberculosis, and if known those age groups that are affected. Still on pathology, we shall see the Cutaneous necrosis and granulomatous formation with a lot of bacteria seen. Then commonly we see these disseminated macules usually on the trunk, thighs, buttocks, and even the genitalia. So when you are making the diagnosis, which will depend on a skin biopsy, sometimes the tuberculosis may be different or sometimes positive. And when you see disseminated TB going everywhere, you have to think about possible drug resistance. So in this case, you may need to do culture and sensitivity, and then you see which drugs are effective in that case. So we can also have metastatic tuberculosis abscesses. And so in this case, someone will have different gumas or different swellings on the body, which are just disseminated TB. So you have gumas or subcutaneous nodular swellings. So the major cause is usually Mycobacterium tuberculosis, and it can occur where you have reduced resistance and your immune system is down, so you have now disseminated TB under the skin, which ends up giving these different nodules. So sometimes the spread is thought to be hematogenous. So you have TB in the lungs, it goes into your blood, and it ends up in, like it's macrophages in your blood, then they end up being disseminated in different body parts where they do homing and end up causing subcutaneous involvement or cutaneous involvement. So the key factor, someone can have either single or multiple forms subcutaneous nodules that later on ulcerate and break and affect the surrounding skin. And sometimes it can be looking similar to scrofuloderma, as you can see in this picture. like here. So this one started as nodules, then later on they ulcerated to give you this picture, which is similar to scrofuloderma, but in this case, it is cutaneous TB abscesses or TB gummas. So these nodules are usually non-tender, they are fluctuant, and oftentimes in the extremities, they can ulcerate and then form fistulas. The differentials you can think about other pathogenic bacteria infection, syphilis, the atypical mycobacteria, or even deep fungal infections. So management still anti-TB medicine depending on your guideline. So looking at the different variants that can occur in someone with very good immunity, or if someone was vaccinated and they're not naive host, the first one is the wart-like tuberculosis, which is also called tuberculosis verrucosa cutis, or anatomy's wart, also called prosector's wart, or even verruca necrogenica. So in this case, someone will present after inoculation of the TB into the skin, and in this case, they have a high immunity, so the body will be able to localize the TB in that area. And because of the aggressiveness of the immunity, so someone will end up with these warty, slow-growing lesions that may look similar to warts, or the verruca plana, or the verruca vulgaris. So this is common in Asia, and it was where about 40% of the cases occurring in Nepal, and then 18% of the cases occurring in Pakistan, and then Bangladesh. So in the pathology, it will give you that pseudoepitheliomatous hyperplasia, as we see maybe in Kaposi sarcoma and all those other malignant conditions, but with past TB. So sometimes you can even fail to identify a single bacteria of TB. Usually causative organism is the Mycobacterium tuberculosis, and commonly we see infections are found on the hands, knees, ankles, and the buttocks. So as you can see in this picture, you have this verrucous plaque uh, that is usually well demarcated, slow growing, and sometimes you can have the adjacent or the nearby lymph involved. When you take off a biopsy, like a biopsy was taken off here, you see that pseudoepitheliomatous hyperplasia, and then if you're lucky, you're able to pick the mycobacteria on past staining. So in the clinical picture, sometimes you get this slow enlarging of waterplex that usually publish or reddish in color. Sometimes someone has no symptoms, but just you see some of them discharging pus. And you have to make sure that you differentiate it from other causes that can follow sporotrichoid pattern, like in this picture, like plastomycosis, syphilis, actinomycetes, or even like in Vanus, the hypertrophic type. So management still antibiotic medicine. So as you can see in this picture, sometimes the verrucous TB can give that sporotrichoid pattern. So you see this water lesion on the fifth digit, then someone gets these lesions that are following these lymph nodes here. So that's what we call the sporotrichoid pattern. Then we have the lupus vulgaris, or the vulgaris just simply means common form of something. So lupus vulgaris is the common form of cutaneous tuberculosis. So this one is looked at as a chronic progressive post-bacillary form. So in this case, you have very few bacteria in the skin. And in this case, the individual is previously sensitized. Either they have ever suffered from TB before, or they were vaccinated. So in this case, sometimes you get these soft reddish brown papules or even pustules, sometimes ending up to be plaques that show apogeria appearance on dermoscopy. So in this case, this is how they will look like. Though this apogee appearance is also seen in sarcoidosis. So when you see it, you have to make sure that it is not sarcoidosis. So etiology is usually the underlying tuberculosis over either the bone, lymph node, or something that ends up being spread to the skin through blood or lymphatics, or even re-inoculation or reinfection. So this type is usually common in India, South Africa, Pakistan, Spain, and it has been seen to be more in women compared to men. And in the pathophysiology, it can occur due to either reactivation of latent cutaneous focus. Maybe, we've seen TB causing latency. Then after that, after sleeping for some time, when it sees your immunity is going down, then it wakes up, then it will give you such a picture. Or it can be due to direct inoculation, and this can be also a complication of the vaccine of the BCG vaccine in an individual who has a prior exposure. So it is usually characterized by peripheral lymphocytes on histology with the scanty central necrosis, which is usually tejas necrosis of the granulomas that you find, but it's usually very, very, very hard to demonstrate the bacilli in this case. So unless when you do like a PCR on this sample, then you will be able to pick the DNA of the bacteria. So when you do PCR, you are not able to see whether it is still alive or even dead bacteria. So in this picture, as you can see here, someone has this verrucous plaque on the hand, and this is they are warty. So this is what we call verrucous tuberculosis or lupus vulgaris. So the clinical presentation, the initial lesion can be small red purplish, it can be flat topped plaques, and they usually have the central extension. So mainly they can be on the head, arms, and also in the lower limbs and buttocks, especially in the developing countries. And this usually also has different variants. It can have a plaque form, it can have ulcerative type, even mutilating sometimes, just like leprosy and other conditions like rhinoscleroma. And it can also be like vegetative form that you see, like the one we've seen here. And sometimes it can be like a tumor, as I'm going to show you like in another picture. I'll show you in another picture. Then it can also be a papule or nodule. Now look at this picture. So in this case, this lady here had these lesions on the face, which we're actually looking like systemic lupus erythematosus. But then when you do a tuberculosis test, like you can see on this hand, it has a significantly positive. So this was actually TB of the skin, or what we call the lupus vulgaris. And so in the clinical picture, so you can also do someone can in the clinical picture, someone can end up with extensive scarring. You can end up with contractures, ectropion, depending on the area that is affected. As you can see here, we have now this vegetative plaque that is having extension at the borders, and then some little bit of central clearing. And this is also lupus vulgaris. So in long-standing cases, they have been shown to actually patients to develop eventually squamous cell carcinomas in about 0.5 to 10% of the cases. Other cancers that have been reported include the basal cell carcinoma, melanomas, and also lymphomas. So mucosal involvement has also been reported, also involvement of the cartilage that results in two deformities. So still in the management, because of the procibacillary nature of this condition, it is very, very, very difficult to diagnose. But you have to keep it at the back of your mind that it can exist. So when you have a patient that you suspect, you end up actually witch hunting for it, and then eventually you can make the diagnosis. So PCR and culture are very useful in confirming the diagnosis as well as the tuberculin test. So if the tuberculin test is positive, now it gives you the idea. So if it is positive, then you can end up maybe go and do a chest X-ray. Then if someone also has features on the chest X-ray, then you can also now come to the skin, take off a biopsy, then request for H&E as well as pass staining. So you end up if where you are it is possible, you can as well as do the Z and N staining, the modified Z and staining, the acid fast staining, and then you can be able to pick some bacteria from that tissue. But in case you see long-standing lesions on the mouth, you have now to know the infectious causes that cause these things, including tuberculosis. As you can see in this patient with this involvement of the nose. So in this child that you saw, so had this ulcer that was extending, involving the nose for a very long time, about 2 to 3 years. And when you take off a biopsy, then you're able to see granulomatous granulomatous infiltrate, and then you're able to see caseous necrosis at the center, but we may not be able to see the bacteria. So you treat for TB, then the patient got better. We treated for TB, the patient got better. So we can have other deformities that can come with with lupus vulgaris, including deformities after it has healed. For example, in this nose of this gentleman, this deformity has come after treatment. Then in this picture, this is the nodular type of lupus vulgaris. We say that lupus vulgaris has different variants, including plaque, nodular, vegetative, ulcerative, and the rest. So this is the nodular type or the tumor. This is the tumor type. So we can also have perianal lupus vulgaris. In this case, as we've said, it affecting the near the mucosa. So in this case, we have that plaque. So when you take off biopsy, you see TB in there. So after treatment, this is how the patient looked like. And then we've said that sometimes it can complicate into a squamous cell carcinoma. So in this case, the child developed the squamous cell carcinoma after being treated for the lupus vulgaris, which was affecting this entire limb. So these are serious conditions that in case you see them, you need to act very fast. So in this case, this lady had basal cell carcinoma in an area that was previously affected by the lupus vulgaris. So we have what we call id reactions in tuberculosis, and an id reaction is just an hypersensitivity reaction to either the bacteria or the components of the bacteria after either you started treatment or even before starting treatment. So your body maybe wakes up as a form of immune reconstitution, then it will detect the components of the bacteria, then it will start fighting those components. So in this case, they can be due to type 3 or type 4 hypersensitivity reaction. You know, in type 3, you have immune complexes. Then in type 4, you have delayed T cells activation. Then you have the responses. So in this case, the activation is targeted towards the immune complexes that form between the antigens from the TB and your antibodies. Then when they're deposited in the skin, then someone ends up with inflammation. Or if the patient in the immune system wakes up, maybe after if they have HIV, treat HIV, immune system wakes up, then it starts to fight the TB that is underlying. So in most of the times, patients who get id reactions have organ TB. So you have to stay to look for it. So the first one, we call it the lichens scrofuloderma id reaction. This one is also called the lichenoid TB reaction. So it is a little bit rare type of tuberculin, but it was first described by Hebler in 1868, and it will present with very tiny, minute lichenoid papules, and it's common in children and adolescents with active tuberculosis, and it's associated with a strong positive tuberculin test, and it's also called the tuberculosis cutis lichenoides. So in this case, as you can see in this picture, the child has very minute micro lichenoid phytopt papules, and that is what we call tuberculosis cutis lichenoides. It's an id reaction. So lesions are usually 0.5 to 3 millimeters in diameter. Skin color, they can be dermatous. Most of the time, they are asymptomatic. They are typically perifollicular, and they can be in groups, or sometimes they coalesce to form plaques. They can have an annular arrangement like lichen spinulosus, and predominantly they love affecting the abdomen, the chest, the back, and the proximal limbs. Common in children, and we've said, and adolescents. So there's no gender bias in this case, but we see it commonly in the sub-Saharan Africa. So you see these lichenoid papules that are grouped. So that is TB. So sometimes it can also present like the secondary syphilis. So, or like fistiosis was there, as you can see in this picture. So when you see this picture, someone has TB, then you can think about an id reaction that is coming from TB. And as we said earlier, this is a type 3 hypersensitivity reaction, and it is thought that it is due to hematogenous separate of the tuberculosis into skin, triggering an immune response in the skin. And histologically, you'll see superficial dermal granulomas and that are around the hair follicles with ecthyroid cells and lymphocytes surrounding the area. So in this case, it may be very hard for you to see the Mycobacteria, and you can only do a PCR where we pick the DNA of all the gene of these bacteria. So this is still another one, another picture to show you the lichenoid tuberculosis, that how you can look like. In this case, you have like this lichenoid flecks on the back of the patient. So up to 73% of the cases usually have underlying TB focus, which can either be in the lymph nodes, can be in the lungs, the bone, or even the intracranial sites. So treatment, you just give the TB treatment, and these lesions will clear in about 2 to 4 weeks, actually without scarring. So we have the second tuberculate, the one we call the papillonecrotic tuberculate. So in this case, you have papules that have a necrotic center, and this is also a rare type of tuberculate, but it's also called the tuberculosis papillonecrotica. Just to recognize the word, but this is the papule, and it has a necrotic center. That is a papillonecrotic lesion. So this is also common in children and young adults. Presents as sometimes as clusters of small lesions, sometimes as edematous papules, but later on they become necrotic and then evolve into ulcers that can heal with a varioliform scarring, like the ones we see in chickenpox, or sometimes they end up to look like prurigo nodularis, and this is usually symmetrically affecting the other sides of the body, and they can be on the trunk, buttocks, and also genitalia. So in most of the cases, up to 75%, you get a TB focus somewhere else, and they respond very fast to anti-TB treatment. So when you have a HIV infected patient or someone living with HIV, then they have this pruritic nodular necrotic papules. You may end up also screening them for TB to make sure that it is not actually papillonecrotic tuberculate. So in the pathophysiology, this type of tuberculate is thought to be an immunological reaction to occult tuberculosis, possibly linked to hematogenous secret or blood spread. And in the histology, you will see this lymphohistiocytic vasculitis, and sometimes you have vessel destruction, you have coagulation necrosis around the vessels, and the causative agent usually primarily is TB and Mycobacterium tuberculosis, but also it has been reported in Mycobacterium avium, intracellular complex, and then also the M. bovis. So still treatment and TB treatment will help you resolve these lesions in no time. So then we have the next reaction that we call the eczema induratum of just Bazzini's disease, or just simply called nodular vasculitis. So in this case, someone has TB, then they end up with a reaction that affects the fat tissue or the panniculus, and then also affects the blood vessels in that area. So in that case, it is a form of tuberculosis-associated panniculitis, and this is just inflammation of the fat tissue and primarily affects the lower limbs. So that's why you see in this picture, in these areas here. So, and it is usually symmetrical and typical. Usually this diagnosis is easy to make clinically because of the known locations of the erythema induratum. So in this case, we usually see it in young to middle-aged women. Most of the cases, up to 90%, they occur in women, and they can present with pain, tenderness, erythematous nodules, flakes, or sometimes ulcers, mainly on the calves, extending. Sometimes they can also get similar lesions on the upper limbs, buttocks, or even the trunk. And the causative agent in this case is the M. tuberculosis, although other pathogens like bovis and Chelonae have also been reported. So you have to do a tuberculosis test in this case, and it will be positive, and this is what confirms the association with tuberculosis. So in the pathophysiology, or in this histology, you see lobar panniculitis with vasculitis. Sometimes you see occasional granulomas with central necrosis, the picture we usually see in tuberculosis. And the diagnosis can be made on clinical presentation. Then you do a tuberculosis test. You can also do a PCR, look for the DNA of the bacteria, and then as well as other histological pictures. So you combine the clinical, the lab, and the histology. So treatment still anti-TB medicine, but sometimes you may need to give some NSAIDs and compression bandage to help with the panniculitis and the pain on the sides. And then we have these other tuberculosis that have also been reported, but rarely. The first one is the erythema nodosum. This is usually caused by also TB, especially in the Western countries, but also more common in areas with high TB prevalence, like in Uganda, and commonly seen in children. You can also get nodular fasciculitis, although this has been said to be similar to the erythema induratum or of Bazzini. So in this case, the only difference is that you don't get ulceration as we get in Bazzini. We can also get lupus nephritis disseminatus facie, where you get uh, like a rosea variant. In this case, you have areas with people with TB, and then you get this rash that is on the face that looks like rosacea. So it has been also thought to be related to a hypersensitivity reaction to TB, but because it also responds very well to TB medicine. So every time you see a patient with rosacea in a setting where the prevalence of TB is high, please think about lupus nephritis disseminatus facie. And we can also have tuberculosis mastitis, where the TB is now is affecting the mammary glands that are the breasts. In this case, you will have chronic form of granulomatous mastitis, mimicking the breast cancer or even extramammary or even the Paget disease in that case. So in this case, if someone have nodules, ulcers, abscesses, and they respond well to TB treatment. For example, in this, so now this is the lupus nephritis disseminatus facial that you see here that looks like rosacea. Then after treatment, you give it that little scarring. Then you see this granulomatous that mastitis that can actually look like breast cancer, Paget's disease, and squamous cell carcinoma. So when you see such lesions, you have also to think about the infectious causes that can present in a similar way. So thank you very much for attending this wonderful lecture for dermatology, where we are looking at TB. So that is how TB looks like on the skin. And oftentimes, when you tell people that TB can affect the skin, they think, no, it can't. But when you see people with ulcers that are not healing, lesions that are not typical to what you know, you treat with other medicines and there's no improvement, we need to also to consider this tuberculosis of the skin. I'm Dr. Brown from the dermatology specialist. See you in the next session.